Hello, hello.
Hi.
Hi, everyone. If you guys want to take some time while we let folks into the room, you can go ahead and introduce yourselves in the chat. Let us know where you're from. All right. Welcome, everyone, to a natural capacity building Johnson & Johnson series. Today, we welcome Philip Cooper and Suzanne Porter. I've had the pleasure of supporting Philip in our CHW leaders group. I am a certified peer support worker, person with lived experience, and certified community health worker. I proudly introduce Philip Cooper. He is a Western North Carolina native and an accomplished re-entry expert, criminal justice reform advocate, and regional change agent. He is the Inspire coordinator at the Land of Sky Regional Council and the founder of Change Agent Cooper LLC, where he provides program development and supervision for community health workers and peer support specialists. He is the founder and co-leader of Voices of, Philip, help me out with that word.
Affrilachia.
Affrilachia, which is a state-funded initiative that is addressing the mental health stigma in the Black communities of Western North Carolina. He recently started an organization called Operation Gateway, which he utilizes community health workers with lived experience and prison reentry. He is connected to returning citizens to resources upon release. Philip believes that those closest to the problem are closest to the solution, and this is why he is fully committed to teaching people how to leverage their lived experience to change the world. He is an MLK Service Award recipient, an Appalachian Leadership Fellow. He is a Leading with Conviction Fellow with Just Leadership USA. He serves on the Juvenile Crime Prevention Council and is the chair of the Just Economics WNC Board of Directors. His co-presenter, Suzanne, has worked for United Way of Rutherford County for more than a decade. She helped establish UWRC's Substance Use Prevention Coordination in 2008. Since then, UWRC's focus has expanded to include increased access to treatment, harm reduction, recovery, reentry supports, and other social determinants of health. Suzanne works in community mobilization, program development, and grant writing, and has been instrumental in procuring millions of dollars of new resources for Weatherford County. This includes the creation of North Carolina's first medicated assisted treatment program in the County Detention Center and UWRC's reentry program. She is the project director for UWRC's HRSA, our court implementation grant. The grant initiatives include creating a mobile harm reduction team and a community recovery and health healing center. A graduate of the University of South Florida, she is a former journalist and program development volunteer recruitment director. She discovered her love for advocacy and community development while working for the Hillsborough County, Florida court system. Suzanne serves on numerous boards and councils, in addition to serving as the vice president of the board of directors for addiction professionals of North Carolina. She also has lived experience as a person with immediate family members with substance use disorder or co-occurring disorders. This personal and professional perspective solidifies her commitment to serving and advocating for the individuals and families whose lives are impacted by substance use disorder and the professionals who are dedicated to helping them. Without further ado, Philip and Suzanne.
Bless up, everybody. Bless up. Good to see so many of these. Look at all this diversity on this Zoom meeting. Hallelujah. Y'all doing the good work, man. It's just so exciting. And I know we all got shared values and similar passions because we all live out power to the people. If you hear me, let me see you drop something in the chat. click on your emojis or something, but turn up, because listen, we finna get lit today. We finna talk about how you can address mass incarceration, how you can slay stigma, and who else better to do it than CHWs. Let's see here. Finna share this screen. Y'all better be glad we ain't in person. For real, one day it's gonna happen and we really gonna get lit. Suzanne, you wanna start it off?
Sure. Good afternoon, everyone. Thank you so much for having us. Very appreciative of this opportunity to be here with my esteemed colleague, and I call him my wonder twin, Philip Cooper. Philip approached me about being part of this presentation, and I'm just delighted to be here.
Right on. And my name is Philip Cooper. I am a community health worker, lived experience with incarceration, a man in long-term recovery from substance use disorder, with over 13 years of uninterrupted recovery. I'm a family man, but I'm a community man, you feel me? And a lot of y'all can probably identify with that, because we know at the end of the day, like if our people are still struggling, it's hard for us to sit at home and be okay with that. So I've committed to this work. I'm here for the ride, and I'm very excited to co-present with Suzanne. One thing that you will hear us talk about is how we initially got connected, and we all know that you got to have those allies, but all allies ain't created equal either. You know what I'm saying? There's a lot of people that got woke after George Floyd. I'm not talking about just those. I'm talking about the ones who was woke before then. You feel me? And as we go to this video we about to show, I want to let y'all know something. Like we're showing this video, and it is an animal that's being used in this video, but do not get it twisted. By no way, shape, form, or fashion am I saying that people that I serve are animals, but there is a point that we're looking to make with this video. Listen up.
Hi, nice to meet you. Can I say hello to you? My name's Tom. You can say hello. Hi.
I noticed that we were cowering. We had our head down. We were looking up with the eyes. So in other words, we weren't posing a threat to me. We were just very, very scared. So that's why I felt comfortable enough to lay down on my back and offer my face. It's kind of a sign of submission to a submissive dog, saying, I'm not going to hurt you. I could easily go over to this dog, put a muzzle on, strap it on, say, okay, I'm going to lift you up, put you on the table, do my physical exam.
You are no longer in the corner.
I would have got just as much done. However, what's the lasting damage that would have happened for that pet versus building some trust?
You like that? Does that feel good?
You can see their reaction with just some kindness in that video of just how we start to trust.
Hi.
All right. Suzanne?
So I want to reiterate what Philip said. One of the reasons why we chose this wasn't to equate people with animals, but to show if a veterinarian can apply trauma-informed care with animals that don't even speak the language that he speaks verbally. For us as humans, we should be able to do this. And it's such a powerful transformation when you see that dog cowering in the corner versus how it ends on the clip where Philip cut it off. And we just feel like trauma-informed care, I always say, and our staff gets tired of hearing me say it, trauma-informed care is a verb. And so it is our mantra in our office, in our agency, and we just thought this video really demonstrated that in action. And it's not always easy to see trauma-informed care in action that we can actually visually show in a presentation like this. So we really just thought that was a great video to kind of kick things off and show where we're coming from.
So the question, and even Michaela, it was funny because she couldn't pronounce Affrilachia. So let's just go ahead and put this out there. There may be some people in the chat who are from the Affrilachia, and that's where we're located in the Appalachian Mountains. but the Black folks that we call it the Affrilachia, right? The Affrilachia. And the relationship, like I said before, man, it is very, very critical for you to have good relationships, healthy communication with those allies. You got to have the right allies, right? And so Suzanne and I first met back in maybe like 2018. Suzanne, was it 2018 at the reentry conference? Was it 2018?
2017-ish,
Yeah,
somewhere in there.
2017, we was at a reentry conference. Our state has a prison reentry conference that they throw on, and all the folks come out, share about their programs and best practices and updates. And Suzanne was having a debate with another white female. And so, you know, I was ear hustling a little bit because I had met Suzanne before, but I didn't really know her like that yet. And so I heard her debating with another white female who was basically complaining because there was another white female who was complaining about it seeming like people was just talking about race. And because the other white female had actually served prison time and stuff like that, but Suzanne checked her and she was like, you need to check your whiteness and check your privilege. And I was like, oh, snaps. And when I heard her starting to talk about, you know, the privilege and how the experience is different for white folks than Black folks, even with reentry, you know, at that point in time, me and Suzanne's relationship clicked. And we stayed in touch like really ever since then, because she's doing work in a county that I was born in, which is a rural area. And we stayed in touch. And so how we got to Voices of Affrilachia was really what happens in this area is like we see the stigma, we see the mental health stigma. You hear Taraji P. Henson talking about it, you hear Charlemagne the God talking about it, and we understand that there's a stigma in the communities of color that keep us from asking for help. A lot of times it's the lack of diversity in the mental health workforce, right? And so what ended up happening was I contacted the state board, the North Carolina Addiction Specialist Practice Board, and I contacted the board chair and I asked for some demographics. I needed some data pertaining to how many Black clinicians there were in Western North Carolina, how many licensed clinical addiction specialists there were, how many certified substance abuse counselors there were. And whenever he gave me the data, it was terrible. Like, we can't end the stigma if we don't have diversity in the mental health workforce. And I'm glad that they were willing to give up that data. And so I took that data to the Zedek Fellowship. And with that data, they wanted to address things. They wanted to address the inequities. And so they contributed to starting something called the Clinician of Color movement. And with the Clinician of Color movement, we address the inequities by funding. And to address inequities, you have to invest. You know what I'm saying? Everybody want to talk about equity these days, but are they really ready to talk about investing in addressing the inequities? And so at this time we had funding, we addressed the cost associated to becoming a counselor, the cost for supervision. See, there's a lot of things that people don't take into consideration. Like, it is challenging to get into that workforce, right? And so we addressed that. And one time I was on LinkedIn, and for y'all that don't have a LinkedIn account, call to action. Hello, it's time for you to get you a LinkedIn account. Throw you a picture on there. It ain't no different from Facebook. It's a way for you to network doing business. And I was on LinkedIn and I was like raising awareness about the Clinician of Color movement and got the eardrum of the director of the North Carolina Department of Health and Human Services. He's seen the video. And so they asked for a meeting. And when they asked for a meeting, they was just wanting to learn more. They was like, where are the Black people at in Western North Carolina? That was one of the questions they asked. And I was like, oh, we up here, you know, we just ain't hanging around downtown where it's gentrified, you know, in the breweries and stuff. We out here though. And so they say, can you put together a listening session? And now I'm gonna go back a little bit where I told y'all it's very important for you to have solid, trustworthy allies. And as community health workers, y'all already know what time it is. One of the most important, if not the most important shared value that we have is trust. That is the most important value. And so I thought about, like, what nonprofit do I trust to call on who can help with this administrative piece of putting this listening session together? I reached out to the United Way of Rutherford County, and boom, we put together a listening session. We had diversity in service providers. We had licensed professional counselors. We had community health workers. We had certified peer support specialists. We had preachers. We had a staff member from the counseling department at the community college. And we held it in a Black organization, the YMI Cultural Center. So it was a safe space, right? And so whenever these state leaders had this listening session from diversity of people of color who are professionals, they turned around and invested. They turned around, y'all hear me? They invested in addressing the inequities and addressing the stigma in Western North Carolina in those communities of color. And that's how Voices of Affrilachia was started. Suzanne, you got anything on VOA?
Yeah, so one of the things that I think prompted the interest on our end is I recognize we're a rural county, majority white population. I've been the executive director since August 2017. And when I looked at the programs that we worked on and the work that we did in the county, a lot of it focused around basic needs and substance use and mental health from the prevention side. But there are all of these big gaps in services and supports for people. And one of the things that I am very open about acknowledging is we weren't addressing equity the way we should have been. We weren't looking at disparities. Like even our county community health assessment, you can see the disparities in lifespan. Just the difference between race with your lifespan. I shouldn't say just the difference, that's a huge difference. But I mean, just looking at statistics, it is there in paper in all of the health data that we collected. And so we began a concerted effort to start addressing those health inequities and disparities and beefing up the work we did around recovery, reentry. And so when Philip came to me and said, hey, I have this project and it's really important to me and I need someone that I can trust, of course I said yes, immediately, right away. Not even really knowing exactly what he was doing, but knowing that I trust Philip. And when he is like gung-ho about something, you know it's important. Well, he's gung-ho about a lot of things, but it's really important when you see the enthusiasm coming from him. And so it started off as just this listening session project, and he brought some of the state folks to our office, and we sat here and talked for, what was it, like 3 hours about health inequity in Western North Carolina and what that looks like in rural communities. And when the state came back and asked us, we have some block grant dollars to spend down, what are the most urgent things that you can spend them on? And immediately we both said, overdose prevention and housing. And so we took off running, hit the ground running with that, and then built it from there. So defer back to you, Philip.
So whenever we created Voices of Affrilachia, we came in understanding that there are inequities as it relates to access to healthcare. But a lot of times when people think about healthcare, they don't think about behavioral healthcare. And when I think about like my lived experience myself, when I was in the streets, I remember there was other people who was using hard drugs and they was keeping it on the low and they wasn't going to treatment. And it just goes back to that lack of diversity in the mental health workforce, because people are not wanting to open up to the person that's doing the assessment if they don't trust the person. And if you've been oppressed by a system for so long, you're not going to automatically trust the system to provide the treatment for you because the system ain't treat you in the first place. And so we got to look at how do we address this inequity. Now, the hard facts is a lot of Black folks, they might not go to treatment, but where do they end up going whenever they have untreated mental health issues? They go to prison, they go to jail. And so we knew with addressing the stigma, we had to be readily prepared to serve our brothers and sisters that was coming back home from incarceration. So we're serving people coming from prison, we're serving people coming from jail, and we are serving that population that are choosing to go to treatment. And we have a very good, healthy working relationship with the treatment centers. And, you know, we have that trustworthy relationship to where I know it might sound petty, but I'm being real with y'all. Whenever they have a person of color that comes to treatment, they hit us up every single time, and they understand the importance of it because they know that in this arena, you have to have culturally specific, culturally responsive, culturally aware, and it has to be ready because people are facing stigma, and everybody should be able to recover no matter what color they are, no matter what their culture is. So I said something. Yeah, go ahead.
I was going to say, and to Philip's credit, before he approached me about this, we have a community health worker, and she is stationed in 2 churches in our county. She's embedded there 2 days a week to address health disparities and inequities. And one of them is in a Black church in our county. And one of the key reasons why she is there, like the sole reason why we created her job, was to address behavioral health and stigma in the Black community, because we saw that people were not getting treatment. And one of the things that we did is we went in and we listened. We had a bunch of forums. Philip actually served on some of the panels that we had, and we went in and listened. Like, what is it that we can best do to serve you? And I think that was one of the really important ways that we created trust, is because we didn't just come in and prescribe and tell people, well, we think you should have this and you should have that. And it grew from there. And I just want to say, like, that was our first community health worker. Her name is Kara, that we have on board. And that experience was very eye-opening to me about how important community health workers are in the various settings that we put you in throughout the community.
Yep. And you heard me mention prison and jail and treatment. So those are all places where people are returning to the community from, who may have untreated mental health challenges, who may have untreated substance use disorder. There are different things that they have. There are some similarities, though, when you look at prison and jail reentry, and I've been trying to be as loud about this as possible. Some of y'all in here that offer reentry services, you could attest to this. But people getting out of prison and people getting out of jail, they got some similarities, but there's also some differences. When they're getting out, you got to have housing, food, vital records, continuity of care, whether it's medical or mental health, whatever it is, chronic illnesses. Shout out to the FIT program. We have this program in North Carolina called the FIT program, but all counties don't have them. And when you look at the rural counties like Rutherford and Polk and McDowell, we got to be creative on how we make sure that there's continuity of care, because the prisons are short-staffed. I don't know how it is in y'all states, but here the prisons are short-staffed, so we really have to step it up a notch. Culturally aligned and specific peer mentoring, that's major, because all people's reentry experience aren't the same. And of course, education, employment, those things like that. But we cannot forget about healthcare. And as a community health worker, we're looking at addressing those social determinants that impact the health, those social drivers that impact the health, and all those things listed there, and some that's not listed there, can impact a person's ability to access healthcare. So those are some of the similarities. Now let's go to the differences.
So we started our reentry program in 2018, and it followed on the heels of starting the MAT program in our county jail. And that program is where we really saw just what a amazing gap. Gap is not even the right word. It was like the abyss of lack of resources for people leaving incarceration, leaving treatment, people trying to maintain their recovery. And so when we looked at creating a reentry program, we decided that we needed to serve people returning to our county from prison, but we also needed to look at people who were serving time in jail. And at that time, there were still people serving state misdemeanor confinement sentences, so they would be in jail for months. And we recognize they have a lot of the same needs, even though it's different in that sometimes we have people who, they're not convicted already, they've not been through the process. Often our jail, as we all know, it's a revolving door. And we had to be mindful of that. Like, how do we serve people who are getting arrested frequently and they're spending a few days in jail and then they bond out and then they're back in a week? How do we serve them and be mindful that we have limited resources? And also the continued substance use piece. If people are back and forth between jail and the community, those with substance use disorder are generally what we see. I'm not trying to stereotype people, but the reality of what we see is they're typically returning to their same social networks and re-engaging in substance use. And if we're really being honest, we know that there's still substance use that goes on during incarceration, and that's not always an easy conversation to have or one that people like to talk about. But if we're being realistic and honest, that's one of the pieces too. And so we really, when we were looking at those differences, wanted to make sure that what we were doing was effective for all of those situations, and recognizing that it was more nuanced than just, okay, they've been incarcerated, we've got to treat everybody the same way and have this cookie cutter approach. And so we've learned a lot from working with people leaving prison and people leaving jail, and how we can put together services that really help everyone, but still tailor and adapt them to best meet people's needs.
Yeah, and when we look at, the prison reentry side, longer sentences, we've had people come out, during the pandemic, and jobs are telling them, you have a job interview on Zoom. What is Zoom? You know, they don't even know how to work a smartphone. And so we understand, like, those people that's been locked away for a long time, they need more hands-on approach. And often they're coming from further away. You know, there are times whenever they want to release them connect with us last minute, and then they want to put them on a bus. It's just so many barriers that they face. And a lot of it, I would say, is due to the staffing issues. You know what I'm saying? I'm not going to come on here and just bash the Division of Public Safety, but what I will say is that the staffing issues is impacting the reentry plans, and some of the case managers do better than others. Like, there are sometimes whenever we connect with a case manager and we say, hey, you know, a family member reached out to us about so-and-so, and we're here to support you in this reentry plan. We're here to help. Some of those case managers are jumping on it ASAP, like, oh my gosh, thank you so much. But some of them is crickets. You know what I'm saying? So I'm guessing that these staffing issues are impacting their passion, their ability to effectively do their job. And with the reentry side, you've seen on the I'm gonna go back to the let me see. Well, I ain't gonna go back. I was gonna go back to the picture that was on the other side. You seen me at the DMV, at the Division of Motor Vehicles. Guess what? In our state, they got it on appointments whenever for somebody to get an ID. You know, how are you gonna get an ID 2 months later down the road? And so there were times we had to show up with our people. You have to get out of your cubicles. You have to get out of your office, boots on the ground. You know what I'm saying? Advocating for your people. And like, there were many a times we go there to the DMV and we talk to a staff member at the DMV and say, hey, you know, this person just got out. We really need your help. You know, I want to help them get a job, but to get a job, you got to have 2 forms of ID and you know, and touching their heart. You know, when I was on a webinar before, or a national webinar, and I remember hearing somebody say that community health workers are experts at figuring it out. We are experts at figuring it out. You feel me? Power to the people. It ain't just us talking. You feel me? We are experts at figuring it out, advocating for our people, telling our people stories. Because at the end of the day, if they're being oppressed, we're being oppressed. And I ain't having me be oppressed no more. So we mentioned culturally aligned and specific peer mentoring. The word culture. Denzel Washington is finna tell y'all a little bit about the word culture. Check this out.
Could a white director not have?
It's not color, it's culture.
Explain the difference, because I think we're
Steven
in a space
Spielberg
right
did Schindler's List.
Mm-hmm.
Martin Scorsese did Goodfellas, right? Steven Spielberg could direct Goodfellas. Martin Scorsese probably could have done a good job with Schindler's List, but they're cultural differences. You know, I know, you know, we all know what it is when a hot comb hits your hair on a Sunday morning, what it smells like.
Huh?
That's a cultural difference, not just a color difference.
All right.
So it's the culture.
You know about the hot comb? Scenario?
No, she don't know about no hot comb. You don't know nothing about it.
So I'm wondering how many people, if you want to drop something in the chat, I want to see how many of y'all know about that hot comb and that smell of that hot comb. Y'all know about that blue magic, but it is a difference, you know. And like, there's probably some people on here right now who've served prison time, right? Who made, like, they call them different things. Michaela said on her side of the country, they call it spreads. In North Carolina, we call them swoles. A swole is a very tasty casserole that you can crush up oodles and noodles, put them in a trash bag, crush up some chips, crush up some toast cheese crackers, cut up a summer sausage with your ID card because you don't have knives in the penitentiary, put some very, very hot water, flatten that thing out for a little bit, and voila, you got something like a macaroni casserole with some meat in it. You know, that's a culture thing. And when I'm meeting with a client and the client doesn't want to open up, and I start being able to tell them some of those stories from when I was in prison, it's a culture thing. It's a culture thing. It's a lived experience thing.
So on the treatment and recovery side, a lot of people that we serve, and just to be clear, we didn't really specify. So Voices of Affrilachia, we cover a 7-county footprint across Western North Carolina. And so in our region, we have some smaller rural counties that have not a lot of resources at all. And then we have Buncombe County, which has Asheville, which has a lot more resources. And so we see people kind of going back and forth. We have people who are relocating, getting out of the smaller counties and going to Buncombe County because they're getting away from either the social network that they were part of that they no longer want to engage with. We have some who leave because they are finding jobs that pay more or because there's public transit. Those are some of the big problems that we face are the housing and transportation. And I apologize that I'm looking off to the side. I have to use my phone for this, so I'm looking at my phone and not at the camera. So if that looks weird, I apologize. And so transportation and housing are the biggest problems that we face. And there is a lot more transitional and recovery housing available outside of most of the smaller counties that we serve. And so we do see a lot of people relocating once they leave treatment. The continuity of care is a really important piece of it, ensuring that we are connecting people to the resources that they need. And not everybody feels like they need to go to a partial hospitalization program. So meeting people where they're at and helping them get connected to the resource that's right for them is a really important piece of what our folks do. And I mentioned the PHP as the step down from being at residential treatment. And a lot of our counties don't even have that. So that might be another reason why people would go to a larger county. But the ability to meet people where they are and help them go to places where they have resources or where we work together in our communities and create resources, education and employment. We do a lot of work with our community college and with employment agencies that are local. We had a trauma-informed care training today, 2 parts. We have a session going on right now, and NC Works, the local director of our NC Works, is at that training to learn how to better interact with the population of people that we serve who have a history of incarceration, substance use, trauma across the board. And so when we look at the recovery supports that we're building out, we also are really concerned about how trauma-informed we are when we're doing that work as well. And the recovery supports that people need, again, often look a lot like what people leaving incarceration need. If they've been away from their community for a long time, a lot of people go to a program that's 3 weeks. Others may be gone for 60 days, 90 days. And then there are those who, if we're being honest about things, and I live this as a parent. I have a 22-year-old daughter who has been struggling with addiction for the last 4 years. And I have been in places that, as a parent, it breaks your heart to go into, to find your kid and drag them out of. And so when we're being honest about recovery, when people have been living in chaos for years because they're bouncing around on the street from place to place, relearning how to have a job, how to finish your education, how to have stable housing, those are things that people haven't had for years. And for us to think that we should be putting people in transitional housing and expecting them to be able to go right away to a 40-hour-a-week job, to go to their meetings, to go to treatment, and be able to do all of these things that are structured when they haven't had structure in such a long time, how realistic is that? We set people up to fail, and that's one of the reasons why having community health workers filling all of these gaps in our communities is so important, because you're a support that people otherwise wouldn't have. And I know we have peer support specialists, and that's also another key piece of helping people maintain their recovery. But when we look at all of those social determinants of health that have been just completely missing, addiction is the only disease where the sicker you are, the crueler we treat you. When you think about that, the way drug charges work, the way all of it works, it is the only disease that I can think of where the worse you are feeling, the worse you are addicted, the worse we treat you. And it's absolutely inhumane. And I'm not going to get on my soapbox about that because I could talk all day about that. But that is why it's so important for us to have these different supports for people who are trying to maintain their recovery as well. And one of the things, and this is a true story, and Philip and I talked about this earlier, when we started our MAT program in Rutherford County, MAT was not available anywhere else in the county. And we had a press conference to launch the program. It was a big deal. It was the first program in the state, big deal in our county. And we had this press conference. It was live streamed on Facebook. And I got back to my office and I was sitting at my desk and like answering email, and my phone rings and I answer it. And it was a woman who called and said, like, I saw the live stream on Facebook about this program and I really need help. So if I violate my probation, can I go back to jail and be in your program? And that to me, and I'm sorry, like I'm getting emotional. I did not expect to get emotional about that. That's a huge statement, that somebody is willing to go back to jail to get the help they need. And so that was one of the reasons why, when we looked at the gaps in our community and started to create reentry and recovery supports, that was one of the big reasons why, because people shouldn't feel like they have to do things like violate their probation because that's the only place they can go and get a resource that they need. So building out all of this and treating people, whatever it is that they left the community for, treating them all with the same empathy and care and providing those same supports around their health, around their housing, around their stability, it's critical. And so when we created our reentry program, I went for local funding because you can have more discretionary ways of spending it. And we wrote it so that it was for reentry and recovery. Everything I write now, I include reentry and recovery, because if we're being diligent about prevention, and like Philip talked about the disparities in incarceration rates, then let's build in those prevention measures where we're getting people into treatment and getting them help, getting them supports before they wind up incarcerated. So that's a big piece of why we include recovery in all of the work that we do, because I know it's not always something that you hear people say when they go, oh, we have a reentry program. We felt that it was vital to include both of those. Yeah.
And before we get to, and Suzanne, I definitely want you to go in some more about the risk on that next on the next slide. And I'm going to say this, y'all, you know, at the end of the day, the community health workers play a major role in ending stigma. And when we look at, you know, what's going on, even with the overdose, people of color, the rates, I'm gonna let y'all Google the rates because I didn't bring all of those, but the rates for overdoses amongst Black folks is up there. So it's happening. Like, substance misuse is going on in the Black community, and it is up to trusted leaders to be a part of ending the stigma, trusted leaders. And that's where that culturally aligned, culturally specific engagement comes into place, whether it's in the churches, whether it's the guys that come from prison that was in the gang before and now they're healing the community. And a lot of times those are your warriors that you want to lean on, is those people who came from hell already. Who else better to help somebody coming out of hell than somebody that's done came out of hell? And so that's why that culturally specific piece is so important when you're talking about working with people that are coming out of treatment.
So we'll dive into this a little bit more, but I just want to plant the seed for this as part of our discussion as we move through this about harm reduction. The state released some data, the Department of Health and Human Services, and I've looked at a lot of the data before, but one of the stats that came out, that people leaving incarceration in North Carolina are 40 times more likely to die of an opioid overdose. 40 times, like that. You know, to me, that number, I can't even wrap my brain around it. 74 times more likely to die of a heroin overdose. And so if we are not looking at harm reduction when people are leaving incarceration, we're being negligent. Like, I would say we're like beyond negligent. We're derelict in our duties if we're serious about helping prevent overdose deaths. And that 2-week period when people are first released, that's when they're at highest risk of overdosing. So we've got to be targeted in our approach to doing that harm reduction work for people. And this is something that we've done as a community that we're building on. But I don't know, those of you who are familiar with the sequential intercept map, where you look at all of those intervention points where you can help people and where they intersect with the systems, like law enforcement, behavioral health, the emergency room, the court system, probation, all of those places where you have opportunities to connect with someone and do the harm reduction work, do the intervention piece. You know who we've left out? And it blows my mind that we've done this? Our bail bonds people. Who has a lot of one-on-one contact with people who are in and out of the system, particularly local in the jail settings? Our bail bonds people. And we started doing Narcan outreach to them before COVID hit. And that kind of, I am embarrassed to say, got back-burnered in a more systematic way during COVID. But we started working with them again. In all honesty, my daughter's bail bondsman reached out to me because he heard from another bail bondsman that I gave Narcan to that, hey, that's the kid whose mom does the Narcan stuff. And so we have this group of bail bonds people who are now coming to our trauma-informed care trainings. They came to our harm reduction training last week. And so we are trying to build up this network where we're finding new ways to connect with people. And the funny thing is of course, when we were doing this work, Philip's name came up because I knew who Philip was because of the work he's doing in Asheville, because there's a lot of back and forth between our bail bonds folks. But that is an intervention point and a harm reduction point that if we are being serious about those incarceration, the post-incarceration death rate, we've got to start reaching out and working in non-traditional ways that we've not worked before. And the harm reduction piece, I want to be clear, I know there are people who think that harm reduction means that you're condoning or you're endorsing drug use, and that is not the case. We're trying to keep people alive. Syringe service programs, I hear a lot of people say, oh, you're just enabling, you're just, giving people clean needles, you're telling them that it's okay to do that. The reality is, when somebody is addicted, they're going to use whether or not they have a clean needle. So why wouldn't we help prevent disease? Why wouldn't we help prevent them getting bloodborne illnesses and all of those different things that go along with syringe service programs? They don't increase crime. They actually, the studies have shown that crime is reduced in areas that have syringe service programs. And the harm reduction piece, I just feel very, very strongly about, because we see the results. If we can saturate our communities with Narcan and we can help people understand the Good Samaritan laws. I have been there as a parent with my daughter overdosing, and to say that it's frightening is an understatement. To me, if we care about humanity and we're looking at this as a human problem, Narcan has to be something that we use. It has to be something that we distribute, and we have to have these honest conversations in our communities about why it's so important. And the harm reduction side, for people who don't see it from the humane aspect, then we talk about it from the financial aspect. Fine. If it doesn't appeal to you on a human level to save lives, because that could be, someone you love someday in that situation, from the pure financial standpoint of not overutilizing the emergency room for endocarditis and Hep C and HIV and all of the injuries that you can get from using IV drugs and not having a clean needle, or getting an injury and getting an infection and being at risk of losing a hand, a foot. There are people who, when you start talking about it that way, start to listen. And to me, it's sad that like the other side of it doesn't get them, the human side. But we really, if we are being honest about harm reduction, we've got to start reaching out to non-traditional folks in our communities, even our barbershops, our hair salons. People tell their hairstylist things they don't tell anybody else. For some people, their hairstylist is their therapist. And so finding these different avenues of getting harm reduction messaging in our communities is really important. And I think that if we want to stop this wave of overdoses, we've got to have Narcan in as many places as possible. And we have folks who come in, like through our Chamber of Commerce will help us advertise the harm reduction training, and we will ask people, if you take this, we want you to sign a pledge that you're going to keep it somewhere in your business where anybody can access it. And we've had groups of people who do that, and we have folks who come to us repeatedly asking for more Narcan, setting up those traditional informal networks. The good thing is the word of mouth, it travels. So we have people who are leaving jail who will reach out to us and say, hey, like so-and-so is getting out of jail, and I want to make sure we have some Narcan. And so I think the fact that we are honest and genuine in our conversations with people makes a big difference. And that's a key piece of it, that trauma-informed piece, that building trust piece that Philip talked about. Without the trust, this stuff isn't going to happen. People aren't going to call and ask for it if they think that you're a snitch, or you're not going to help them, or you're going to report them to somebody else or tell a probation officer. This is all about saving lives. And Philip, I'm sure you would like to add to some of that too.
Yeah. So transitioning, you know, I mean, you see how we've talked about where the community health workers play a major role, you know, whether it's addressing the distrust of the system, whether it's, you know, getting resources for harm reduction or ending the stigma surrounding harm reduction. There are just so many different ways that the community health worker plays a major role. And just to be clear, just a little bit about my experience as a community health worker, you know, I've always been one, I just hadn't used the title. You know, and I've heard many people say that, you know, even as a certified peer support specialist, you know, there were times whenever I was doing basically the same things that a community health worker does, I just wasn't using the same lingo. And so I have to remind people time and time again across the states, you know, that, hey, you know, just because you haven't been using that title don't mean you haven't been doing the work. And so we want to also make sure that we don't pit peer support specialists against community health workers. Because from both sides, if you look at it, a peer support specialist is basically a specialized community health worker that's working with addiction, but they have to have lived experience. And so this specialized community health worker that we've talked about today, you know, we're looking at returning citizens, and returning citizens can be coming from prison, they can be coming from jail, they can be coming from treatment. And us understanding the racial inequities and the racial disparities with mass incarceration, we got to understand that a lot of people of color end up getting their treatment in the prisons. And so we are looking at providing effective services, trauma-informed services. We got to be readily available to serve those who are coming back home from prison. And we got to understand that culturally specific services are important if we want people to trust us, if we want to link people to care, if we want to let people understand, you know what I'm saying, like, hey, I've been in your shoes before. You know, that changes the whole dynamics of the situation once they understand that we've been in their shoes before. But this specialized community health worker is something that can be replicated. You know what I'm saying? And I want y'all to hear me clearly, because before we go into diving into the lived experience piece to close out, I have a call to action. If you're on here right now, you need a call to action. I got one for you. I see what's needed and what we can do with this community health worker credential with harm reduction, especially in the rural areas, especially in the communities of color where that stigma is heavy. And community health workers, call to action, we can have a specialty community health worker that specializes in harm reduction. Why not? A community health worker is a trusted person from a community that serves as a link, liaison, or intermediary between the community and the resources. How dare we not utilize our trust to leverage the experience of those who got lived experience with addiction, lived experience with mental health, to slay stigma? How dare we not? What better way to leverage, to build capacity in your respective areas than by having a specialized community health worker that can specialize in harm reduction? People are dying. They dying from accidental overdoses. I done lost a couple of homeboys. They wasn't even using that dog food, what they call it, heroin, what they call it, that they say that boy, right? They wasn't even intentionally using it. People lacing everything with fentanyl these days. So we got to get ready, y'all. We are the community health workers. We are the experts of figuring things out. We are the trusted leaders who can get out there and bridge the gaps to the resources. It's our time. And that's my call to action for y'all. You feel me? Because what I want y'all to get from this, not just us highlighting the work that we doing, but please do know this can be replicated, baby. This can be replicated. It is not specific to one area. You can do the same thing we doing. You just got to know your resources, you got to know your trusted leaders, and voila, build a bridge. But Suzanne, y'all heard some of her talking about her lived experience, and we want to go ahead and dive in before we close out, just talking about our lived experience and why our lived experience matters as we slay stigma. So Suzanne, I'll let you go and I'll close out.
So when I started this work years ago, I used to always say, I'm an empathetic person. Which sometimes is a blessing, and every once in a while it's a curse because you feel too much. But I always used to say, when I'm working on programs, I want to build it so that I would be pleased with it serving my family, that I would be good about my family coming and receiving this. And never did I expect, I shouldn't say never, I'm a realist. I know stuff happens, life happens. Little did I expect that a lot of the programs that I worked on building in our county that my family would utilize, that I would have law enforcement in my home and be thankful that they were CIT trained, that I would take my daughter to a walk-in crisis center, that we'd be at the emergency room, that we'd have EMS there because of an overdose. All of those different things have made me see even more deeply the way we treat people. I can compare and contrast with the providers that we've been to, in the way some are trauma informed, some aren't, and the just even dealing in emergency settings, in emergency rooms. When we've been in there because of an injury or something related to drug use, the way we're treated, her, me, everyone involved with our family, versus when we've been there because she has the flu and she's sober. It's night and day. And I know if we get treated like that as a white family, I'm afraid to even think about what that's like for people who aren't white and who don't have health insurance. And I have people who come into our office. We get a lot of, like I said, word of mouth. People come and talk to us, and I have people who sit in my office and who cry just because we're nice to them. I want to say that again. People who cry just because we are nice to them. This is what stigma does. We have people who come in, and I may not be able to fix in the moment what it is that they need. I can maybe connect them to something. You know, there are crisis services we maybe can get involved, but they walk away feeling like somebody listened to them. And with the lived experience that I've had, like I look at people and I think, I don't see that you're just this one thing. And that's what happens when people have addiction, is they get treated like that's all they are. And they get talked to that way, like that's all they are. And I see somebody who's probably been hurt, who's been harmed, who God only knows what's happened to them if they're bouncing around on the street. And I just see people who need to feel connected and cared about. And I don't want anyone to ever leave our agency feeling like we don't care about them. And I can say, having Philip, having Jean, who's on here, Lindsay, I don't know if Lindsay is on here or not, they're part of our team. We have other folks on our team. And I've been very deliberate as we build our programs about who is part of our team. Because this isn't just about a paycheck. This isn't just a job. It's a calling and it's a passion. And if you're not dedicated, then a different line of work is where you need to be. And I'm sorry if that sounds harsh or rude, but you have to have a heart for this to do it. Otherwise, you're not serving people well. And then the lived experience piece means that you really can put yourself in somebody else's shoes, and you understand what it's like to have the door closed when you're trying to get help, or to see how the system fails people over and over and over again. The whole piece, once you're, and I've never, knock on wood, I've not been the one in my family with addiction issues. I have a younger brother who died of a heroin overdose several years ago, and I'm dealing with this with our daughter. And my brother served time in prison and came out of prison and couldn't really find a job, all of the things that happen to people once they've been in prison and once they're a felon or considered a felon. Visiting your child in jail for the first time is a very jarring experience. Once somebody is justice involved, you see how quickly things can disintegrate for them. And so that's why I feel like the lived experience and understanding that and seeing how it happens and can happen so quickly is really important, because I think unless you've lived it, you don't understand how drastically things can change so quickly and in such a negative, awful way. And so I don't want to say that I'm grateful that I have lived experience, because more than anything, I would not want my child to struggle with this. But on the other hand, I am grateful because I feel like it makes me a better community service provider, and it just makes the emphasis be where it needs to be, and that's on people and meeting people where they are and serving their needs and treating them like they matter. Philip?
Sorry. So with me being in control of the PowerPoint, the chat popped up and I was trying to exit out of the chat. But thank you for leaning in, Suzanne, and sharing your lived experience, with being family member, because that's a lived experience that we got to recognize as well. Like, you know, because a lot of families, they get dragged, well, because they love their child, their loved one, their husband, their spouse, you know, so much. And they need a certain type of support, a certain type of linkage to resources, a certain type of intermediary, a certain link, a certain trusted service provider. And who else better than community health workers? And you've heard the call to action, and lived experience does matter, you know, and each area has its own unique needs. And that's where we come in at as trusted leaders to bridge the gaps. You know, my lived experience has been, you know, a Black man in recovery, a young Black man in recovery. I go to recovery meetings in the basement of churches. You feel me? That's what God gave me to get my life in order. And now I continue to go to those meetings to give back and help others. And there ain't a lot of diversity in those meetings, but I'm committed, because at the end of the day, that is a tool that was given to me to turn my life around and then turn around and disciple others. But I do run into other brothers. And when I do, I make it my business to roll up on them and introduce myself and let them know, like, hey, bro, you can recover. Today is the only day you need to worry about, one day at a time. You know, lived experience matters. I know what it was like to be in treatment, to be one of the few people of color that was in the treatment center when I was there. I know what it feels like to come home from prison and get told no after no. I know what it feels like to grow up in the hood in poverty, when the only symbols of success that you see is the dope boys that's in the hood. You feel me? So that's what I want to do, because that's what I see as success. I know what it was like before there was an EBT card, when you was pulling out food stamps out of a booklet and paying for it, but a shame. I remember those days. And so my heart goes out. And at the end of the day, we got to remember, passion is fueled by our lived experience. And may your passion lead the way for your work. So if you got lived experience, man, don't be ashamed of it. The time is now. You know, there are innovative ways for us to use this community health worker credential. And I'm gratefully a part of the National Association, you know, as one of the leaders, and we are definitely up to something. You know, and if you are somebody from the rural areas or an area where the stigma is heavy, please listen up, man. We can realistically do something with a specialty for this community health worker credential that undergirds the trust of the leaders, empowers them and equips them with the harm reduction resources so that they can support the families. Because in those rural areas, guess what? If they ain't got the recovery resources that they need to have the harm reduction resources that they need. And who else better to close the gaps to those resources than community health workers? That's what we do. And I'm gonna end by saying this, and I didn't make it up, but I say it all the time, and I forget who it was that said it originally, but us as community health workers, we experts at figuring it out.
Amen, Philip. Thank you so much. Everyone, this is something that affects all of us in all of our communities. I am a person with lived experience, a returning citizen, and I have felt the great gifts that Suzanne and Philip have offered here today, the support, the community, the relearning, and 95% of incarcerated people will return to their community at some point. So it's up to us as community health workers to take the care and time to rehabilitate those individuals. If you would have told me 5 years ago that I would be sitting here in this room with these wonderful people facilitating the session today, I never would have believed you. But that is just to say that inspiration and hope conquers all. And I want to thank you all for joining today. And I hope you have a great rest of your day. And I hope you join us back for our next capacity building series on June 10th, where we will be talking about the CHW toolkit. Thank you. Thank you, Suzanne. Thank you,
have a great
Philip.
day.
Hugs
Great.
to you.
Yeah, thank you, presenters. Great job.
Yeah,
Thank
great
you.
job. Love
Excellent.
the passion,
Excellent.
the spirit.
Excellent. Excellent.
Wonderful.
Excellent.
Great job. Great job.
Excellent.
Glory.
Bye, Philip.